Good afternoon, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're thrilled to have a pioneer in the field of bladder cancer, Dr. Andrea Apolo from NCI. With Dr. Apolo, we hope to discuss her approach to treating bladder cancer using an algorithm and reiterate the current standard of care treatment options. Without further ado, let us welcome Dr. Apolo.
Thank you so much for the introduction and thanks for having me. This is really fun. I'm really glad you guys are doing this for the physicians in the community who are treating our bladder cancer patients. And, it's just really hard to keep up with everything that's going on in bladder cancer. There's just so much and the field is evolving as more and more of these phase 3 trials are reading out. So I think this is a great idea to kind of walk through the algorithm and talk about how we approach patients with bladder cancer at different stages. Start off with, we divide the patients usually by non-muscle invasive bladder cancer, muscle invasive, and then metastatic disease. And non-muscle invasive bladder cancers are managed by urologists. They're not really seen primarily by medical oncologists. And most of our bladder cancer patients are non-muscle invasive. When we say non-muscle invasive, there can be a range of stages for these patients. Generally, we can divide them into low grade and then intermediate and high grade. For low grade tumors, these are managed with TURBTs, transurethral bladder tumor resections by the urologist, and then surveillance. And then for higher grade tumors, and that includes recurrence of low grade, high grade tumors, T1 or carcinoma in situ, these are managed with TURBT with intravesical therapy. And the preferred intravesical therapy is BCG. In general, there are other options. And there's been a lot of activity in non-muscle invasive bladder cancer in terms of other intravesical agents that are being studied. Right now, pembrolizumab is approved, but it's only for a very small indication. And the indication is really for patients with carcinoma in situ that are BCG refractory and that don't want to undergo a cystectomy. And of course, generally, if you try BCG once, the next step is to try BCG again or try an intravesical chemotherapy, and then only then, if you have carcinoma in situ, then consider pembrolizumab. And this was based on a single arm study. So it's a small number of patients where pembrolizumab was given, and they were looking at the 3-month complete response rate. And that's kind of where the FDA approved this. So really the standard of care is radical cystectomy, but patients don't want to have their bladder removed. New agents that are coming for patients with non-muscle invasive disease that are very exciting and hopefully will allow patients to keep their bladder.
Pembrolizumab was approved in 2020 for high-risk non-muscle invasive bladder cancer. Have you seen immunotherapy being more utilized than compared to radical cystectomy?
Yes, and not necessarily for the indications that it's approved, but it is being used a little bit more than it probably should, given the indication for what it's approved for.
Thank you.
The next stage that I wanted to talk about is muscle invasive. I feel like these are all complicated in their own ways. And muscle invasive is patients that have tumors that have invaded the muscle. So at least a T2, a T3, or T4, which T4 is the contiguous organs of the prostate, the vagina, the uterus. So that's muscle invasive disease. And these patients, the tumors can be very aggressive, and the fear is that they're going to metastasize. So the standard of care forever has been radical cystectomy for a long time. But we see that the patients recur, and most of these recur metastatic. So neoadjuvant chemotherapy has really been incorporated for these patients with muscle invasive bladder cancer. And the trials that have been done have used combination cisplatin-based chemotherapy. We always used to say we don't have a trial comparing all these different chemotherapies, and the primary ones that we've been using are gemcitabine and cisplatin or Gosain and MVAC. And now we do have a trial that actually compared these. But there's some issues with the trial because the trial used 6 cycles of Gosain and MVAC, which is usually what we use in the metastatic setting, and that was used in the muscle invasive setting. So it's a lot for patients to get 6 cycles, and a lot of patients can't get through 6 cycles. And then versus 4 cycles of Gemcis, and the patients that received the Dosins MVAC 6 cycles did a little bit better. But the trial, the way that it was designed, it didn't meet the primary endpoint, but it looked like Dosins MVAC 6 cycles was a little bit better. So I would say that you can still use either one. So you can still use either Dosins MVAC or Gemcis. So now the question is, well, what about carboplatin in patients that can't receive cisplatin? I mean, this is kind of something that comes up a lot. I was brought up that you don't give carboplatin in patients with muscle invasive disease because we just don't have the prospective randomized phase 3 data for giving carboplatin. And in the metastatic setting, carboplatin is inferior to cisplatin by a lot. Now, you can argue that that is because the patients that are given carboplatin are sicker. Not only do they have poor renal functions, but they also have poor performance status. So maybe it's not a fair comparison, and maybe it has to do more with the patients. And I think as we have more large randomized trials in the first-line metastatic setting, and they're using both carboplatin and cisplatin, we may be able to learn a little bit more about these. The problem is that these are not primary endpoints, so these are all secondary exploratory subset analysis. So it's really hard to kind of dig into that. But for now, I don't use carboplatin for muscle invasive bladder cancer patients in the neoadjuvant setting. And then I'll talk about adjuvant. So that's the next step. So then the next step, so you use the neoadjuvant chemotherapy, then the patient goes on to a radical cystectomy. And then depending on their stage, so let's say they in the radical cystectomy, the pathology show that the patient now is no longer muscle invasive. Then you can just follow the patients. Those patients do really, really well and have great survivals, 80% in 5 years. I mean, do really, really well. But the patients that have persistent muscle invasive disease, so T2 or greater, and they receive neoadjuvant chemotherapy, those patients are at really high risk because that means that the chemo didn't downstage their tumor. So it's in a way we use it as a surrogate to what's going on if there are any Rho cells in the body. Perhaps there was no effect from the chemotherapy, and the patient has a higher risk of developing metastatic disease. And this is where the checkpoint inhibitors were tested. And the nivolumab study, the Checkmate 274, was presented just recently and showed that there was an improvement in progression-free survival for the patients that received nivolumab in the adjuvant setting for high-risk patients. Now, that's a mouthful. So it's high-risk patients because these are patients, again, that either had neoadjuvant chemotherapy and had persistent muscle invasive disease, or patients that never couldn't get neoadjuvant or refused platinum-based chemotherapy and had a PT3 or greater. So in those patients, nivolumab improved progression-free survival. And it seemed to be a little bit better in patients that were PD-L1 high, but we'll get to that. I mean, because that gets a little bit more confusing too. Now, again, this was PFS benefit. In terms of OS, is there really a benefit to giving adjuvant nivolumab? I think we just don't have that data yet, and we await the long-term data that hopefully will be presented soon. Now, we have here in the algorithm patients that cannot get cystectomy. Now, I would argue that it's not only for patients that cannot get a cystectomy, thinking about trimodality therapy, radiation with chemo, but also just patients potentially offering this to patients as a bladder-sparing approach because patients don't want to undergo radical cystectomy. It's a little more complicated in that you have to have a multidisciplinary team. So you have to have the urologist working with the radiation oncologist and the radiation oncologist working with the medical oncologist to give the chemo at the same time that you're giving the radiation, and then also doing the scrapings, the TURBT. So that's the trimodality approach. And there's been a lot of interest in adding checkpoints in this setting, and we have seen some really nice single-arm data. So we really are looking forward to some larger trials.
Those are some great points. In terms of NGS, that is not approved in neoadjuvant or early stage setting in bladder cancer. But given the data from GI patient population in ESMO and ASCO, where we saw MSI high patients do remarkably well with IO, any role of utilizing IO in neoadjuvant setting for bladder cancer patients who are MSI high?
Well, you know what? We've actually already had a few studies, single-arm studies using neoadjuvant checkpoint inhibitors, and we are seeing some nice responses that are really similar to chemo, which, was great for us to see. So there's a lot of trials ongoing right now asking the question of giving a checkpoint inhibitor by itself in the neoadjuvant setting or giving a checkpoint in combination with chemotherapy in the neoadjuvant setting. The combination data, surprisingly, didn't look that much better than either just giving chemotherapy or immunotherapy by itself. And I think that we're just overlapping the patients that benefit. They may be the same, the patients that are benefiting from the chemotherapy versus those that are benefiting from the checkpoint. So, but we are seeing activity with monotherapy checkpoint. It's not approved yet. And this is for all comers. Now, for MSI high and patients with mismatch repair, I mean, this may be a really special population where, we can perhaps seize this opportunity for bladder sparing or kidney sparing approach. And this is something, an effort that we have initiated through the Alliance. And hopefully, we'll have a trial, to offer patients like this. For now, we also do see activity just for patients with muscle invasive disease with checkpoint inhibitors, but we're awaiting the randomized trials to see how it compares to standard chemotherapy in a more controlled setting.
Sounds good. Thank you so much. This is a great segue in the adjuvant treatment options. Nivolumab was approved last year for high-risk patients post-radical cystectomy. Now, we know that we have PFS data and still waiting on OS. How much does PD-L1 score play a role here? I know you hinted that initially.
So, great question. We really struggled with PD-L1 testing in our trials and designing trials with the biomarker and selecting patients based on the biomarker. In bladder cancer, we've really struggled, and we say one of the reasons is the heterogeneity of the test, and then all these checkpoint inhibitors have their own tests with looking at different using different antibodies and looking at different cells, tumor cells, immune cells with different cutoffs. So there's a lot of heterogeneity in terms of what we call positive. But in the Checkmate 274 adjuvant nivolumab study, they actually saw that patients that were PD-L1 positive using 1% as their cutoff actually did better. So the hazard ratio for the PFS benefit was higher. For all comers, it was 0.7, and for PD-L1 positive, it was 0.5. So actually in Europe, they said, well, we're only going to prove it for PD-L1 high. But, it gets a little bit tricky because I don't know if we can. Well, the argument is that we are over-treating patients in the adjuvant setting by giving them checkpoint. Not everybody needs it, right?
Right.
But that doesn't mean that if you're PD-L1 low and you have a high tumor burden after cystectomy, after you look at the specimen, that you're not going to benefit. So I don't know if we can exclude those patients yet. So I think it's a tricky situation, and we don't have a good answer for how to use PD-L1 in the metastatic setting or in the adjuvant setting right now. But we do have the data that patients that are PD-L1 high do a little bit better in terms of PFS with nivolumab in the adjuvant setting. With that, I will move on. I know it's a mouthful. I'll move on to metastatic disease. And right now, we split it by cisplatin eligible and cisplatin ineligible. This may become not as relevant as new treatments move to the forefront of first-line therapy. But the standard of care is still chemotherapy. And that is gemcitabine and cisplatin or Docetaxel. And that's really the standard of care. You do that for 6 cycles. And if the patient cannot get cisplatin-based chemotherapy, then you can do carboplatin and gemcitabine. And then if the patient has a response, this is where the Javelin 100 study comes in, showing that there was a benefit to starting a checkpoint inhibitor right after you finished the chemotherapy and kind of maintaining the patient on an immunotherapy while they're getting right after they finished the checkpoint. Sorry, right after they finished the chemotherapy. So there's been a lot of trials kind of asking the question of, okay, well, what about if we give it in combination? Is there a benefit? And so far, they've all been negative. It's really disappointing. So right now, standard of care is still cisplatin or carboplatin-based combination, and then you follow it by maintenance immunotherapy. And avelumab is the one with the phase 3 data. But, others do use pembrolizumab too in the maintenance setting. That's okay too. There is phase 2 data and safety data for using pembrolizumab in this setting too. So that's a mouthful. What about pembrolizumab as a first line for patients that can't get chemo? So we used to use pembrolizumab for patients that were cisplatin ineligible. And then after the Keynote 361 data came out, that there was a very similar study to the INVERI 130 study. This was pembrolizumab plus chemo. Pembrolizumab alone or chemo alone did not meet their statistical threshold for improvement in PFS and OS. So the FDA said, well, right now pembrolizumab is approved for cisplatin ineligible patients, but we don't see that there's a benefit in just giving chemotherapy. So they actually withdrew that indication. And now we said, well, what about the patients that can't get any chemotherapy, which is a really, really small population of patients? And they said, fine, for those patients, we'll keep it. So it's not really based on phase 3 data per se or on data, but it is now an approved indication for patients that can't get any chemotherapy, that they can get pembrolizumab in the first line setting. So that's first line. And then there's other agents that are approved, and then the second line. So then you would get maintenance if you do respond. If you don't respond, you would move on to checkpoint inhibitors, and the checkpoint inhibitors, nivolumab, avelumab, or pembrolizumab, are all approved as second line therapy. In patients that harbor an FGFR3 alteration, erdafitinib is a tyrosine kinase inhibitor that is approved for those patients. Enfortumab vedotin now has 2 approvals. It has approval for patients after they receive cisplatin-based chemo or platinum-based chemotherapy and then checkpoint, and then also for patients that can't get cisplatin-based chemotherapy, but that did get checkpoint. So it's got those 2 indications, so second and third line. And then sacituzumab govitecan is another antibody drug conjugate that is also approved. It's accelerated approval now, and we're awaiting the large phase 3 data. So I know that's a lot, but that's kind of, it's a summary of the treatment for bladder cancer.
Wow.
Thank you, Dr. Apolo, for walking us through that.
Quickly on metastatic disease.
Yeah.
You've mentioned that Atezolizumab with chemotherapy unfortunately did not show OS benefit. However, at ESMO, enfortumab with pembro in cis-ineligible patient looks very promising. There's an ongoing trial for this as well, but as we wait, are you offering enfortumab with pembro already outside a clinical trial?
No, but people are in the community. So patients are coming to me, haven't been received pembrolizumab and enfortumab vedotin, and from, just from the community, not on a clinical trial. So I think the data was very, very compelling, and we are looking for non-platinum based options for these patients. So you're talking about the ESMO presentation of cohort K EV103 that showed the combination of enfortumab vedotin plus pembrolizumab, but this is specifically in cisplatin ineligible patients, and they had 2 arms. They were not comparator arms, but one of them, the patients received EV, and the other one, patients received EV plus pembro, and the response rate was 64.5%, which is actually exciting. I think that's a nice response, and that's equivalent to kind of what we see with, maybe even better than what we see with cisplatin-based chemotherapy. So why not use that? Because we don't have the randomized data yet, I would argue. And for now, we definitely know that cisplatin-based combination has a high response rate, and I think the right thing to do is to wait for the data. There's an ongoing trial, actually completed accrual already, the EV 302 study. And that's what I was kind of alluding to in the beginning, that if we do start using EV plus pembro, then it doesn't really matter whether you're platinum ineligible or not. And maybe this and that would maybe a good thing because sometimes not everybody uses the same definition, and people have it's very subjective sometimes.
Oh, that's true. This field is shifting by the minute. And as we anticipate using more and more enfortumab, can you please share a few clinical pearls in managing the toxicity of this particular ADC?
Yeah, the toxicity that affects patients the most is the neuropathy. About 30 to 40% of patients get, neuropathy that can affect the quality of life of the patient, and that really limits how long we can treat somebody. The nice thing is that, it's basically a weekly treatment, and you can dose reduce, you can hold, you can dose reduce, but we don't have great ways of treating the neuropathy in order to push through the treatment. And there's been a lot of interest in designing trials where we only give like a set amount of cycles, and then we only retreat the patients if there's any signs of disease progression, or we give a certain amount of cycles and then we dose reduce, and kind of, so we're not giving such high doses. That's really one of the, I would say, more common side effects. Of course, there's also rash, nausea, neutrophil count decrease. You can get febrile neutropenia, alopecia. People don't think about that. It is chemo. It's basically chemo given through a more targeted way. But I feel like as medical oncologists, we are good at managing most of these because they're very chemo-like. I think the ones that have been a little bit difficult is the rash. In that there have been reports of severe rash with enfortumab vedotin, and then some really rare organ failure reports out there that we're not sure kind of why that happens. But in general, because it's a weekly dosing, you can usually manage the patient with dose reduction and dose holdings.
Dr. Apolo, one could go on and on. There's so much happening, but thank you so much for taking the time to review this algorithm. Recently, we have seen approval of nivolumab in adjuvant setting pending overall survival data, and now we eagerly await enfortumab and IO data, along with that, how to incorporate ctDNA in bladder cancer. Thank you so much again for going over this algorithm.
Oh, my pleasure. I mean, I can talk forever because there's so much to talk about, and if you don't stop me, I probably will. But there's a lot to talk about, and I think a lot of exciting things going on. And one of the things that we are doing now is combinations to try to see if we can improve outcomes without so much toxicity. So I think it's an exciting time in bladder cancer. And I think this is really important that you're doing this because really keeping up with, all the treatments can be challenging as indications evolve. So thank you for doing this, and thank you for having me. This was really fun.